friends. Today our guest speaker is Dr. Anand Patel from Chicago. He will be speaking to us on treatment strategies for older adults having acute lymphoblastic leukemia. This webinar is brought to you by Mumbai Hematology Group. It is supported by ADLI and managed by Perfect Square. I thank Mr. Ashutosh Shukla and the team from ADLI, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Anand Patel from Chicago. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening from India and morning, afternoon for those belonging to other parts of the world. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have Dr. Farooq Shah speaking to us on thalassemia, updates from ASH December 2024. Our discussants today include a number of very important hematologists or medical oncologists. Some of them are put up on this slide in alphabetical order. I'll keep this slide on for 30 seconds and then show you the other discussants, the other half of them who are with us this evening. And these are the other guys who are with us as discussant. Briefly, to introduce our guest speaker, you all know him. He has been our guest speaker in recent past. He's Assistant Professor of Medicine, Director of the Inpatient Leukemia Service, and Associate Program Director for the Adult Hematology Oncology Fellowship at the University of Chicago. He also serves on the NCCN panels for AML and MPNs. He received his MD from the University of Missouri, Columbia, where he was also elected to the Alpha Omega Alpha Medical Honor Society. He then completed internal medicine residency at the Magog Medical Center of Northwestern University and served as the chief medical resident. Subsequently, he went to the University of Chicago for the Adult Hematology Oncology Fellowship and served as chief fellow. Dr. Patel is an expert in the treatment of acute leukemia and myeloid malignancies. He's also an active clinical investigator with a focus on developing novel approaches in the management of MPNs. He's particularly interested in improving outcomes in patients with accelerated and blast phase myeloproliferative neoplasms. However, today he's speaking to us on treatment strategies for older adults with acute lymphoblastic leukemia. So over to our guest speaker. He will share his screen and give us the talk.
Thank you so much for that very kind introduction. And are my slides coming up okay?
Yes.
Excellent. So thanks so much, Dr. Agarwal, for the introduction. And my name's Anand Patel, and I'm part of our acute leukemia and myeloid malignancy group. And my research and clinical interests are somewhat disparate. And I like to say that, as academic hematologists, we're oftentimes the products of our mentors. My mentors are Dr. Toyosi Odenike, who's an expert in the management of high-risk myeloid malignancies, and my other mentor is Dr. Wendy Stock, who is a world expert in the management of ALL. And therefore, the last time I was here, we spoke about MPNs and particularly high-risk MPNs. And today, I'm going to be focusing on my other major interest, which is thinking about how we can effectively treat older adults with ALL. These are my disclosures. And there are several ongoing studies that I'll reference as well, because I think that's where a lot of the excitement lies in treating older adults with ALL. So, of course, many of these studies will be looking at drugs that are being used outside of their FDA-approved indication. So really, my objectives are threefold. First, I want to set the stage by talking about historically how older adults with ALL have done. I then want to talk about novel management strategies for Ph-negative ALL in older adults, looking at the use of antibody-based therapies such as inotuzumab and blinatumomab, along with the anti-apoptotic drug venetoclax. And then lastly, I want to focus specifically on Ph-positive ALL, given that over 50% of patients with Ph positive ALL are over the age of 50 to 60. So briefly, just thinking about my approach to ALL, really in my mind, there are a couple different branch points. Initially, I think the most important branch point is, are we dealing with Philadelphia chromosome positive or negative disease? And if we're dealing with Ph negative disease, are we looking at our adolescent young adult population, so 18 to 40 years old, or our older than AYA or non-AYA population, so over the age of 40? So as mentioned, today's talk is going to be focusing on Ph positive ALL and then also older adults with Ph negative ALL. So historically, we are making progress when it comes to thinking about older adults with ALL, but that progress, I would say, has been, while significant, still modest. So to put things in perspective, using pediatric-inspired regimens for adolescent young adults, we can expect a cure rate of 75 to 80%. Now, when we look at other different age groups, so 40 to 59, and this is using a large United States SEER database. But looking at that, you can see that the median overall survival for the most recent era, 2010 to 2017, is still only about 4 years. So we still have some work to do. And then as we move out of the 40 to 59 group, our improvements have been very modest at best. So in the 60 to 69-year-old group, less than 2 years median overall survival. And in the 70 and older group, just dismal survival on the order of a couple months, if that. So while there has been improvement in 40 to 59-year-olds, when we think about 60 and above, really, historically, we have moved the needle very minimally, if at all. Here are some select regimens that have been studied for older adults with ALL. And really what I want to highlight is when you think about specifically, again, that population of 50 or 60 and older, overall survival is quite dismal. So you have the CALGB 9111 regimen or the Larson regimen of our own Dr. Larson at the University of Chicago. And when you look at greater than 60-year-olds, there's a 3-year survival of 17% and 17% early mortality. Similarly, when you look at these chemotherapy-heavy regimens, the theme is very similar, which is high rates of complete remission, relatively high overall mortality, early mortality, I should say, and overall survival is quite limited. So when you look at 3 to 5 year overall survival, the numbers that you see are mostly in the 20 to 30% range. Sometimes, for example, the Dana-Farber regimen, you may see something like a median overall survival of more like 2 years, but overall, the 5-year survival rate in older adults with ALL using these historical regimens is not very good. So how do we move the needle forward? In my mind, there's really 2 components. The first is retaining efficacy while mitigating the toxicity of chemotherapy-based regimens. And then the second is we've really had a breakthrough in novel therapies in ALL. So thinking about how we incorporate those into the frontline management of older adults with ALL. So the pediatric-inspired regimen that we tend to use at the University of Chicago is CALGB 10403, which was pioneered by my colleague and mentor, Dr. Wendy Stock. So the curve to the left shows median overall survival not reached in the cohort of patients, about 300 AYA patients treated with ALL, and 3-year overall survival was about 75%. Now, the other, I think, important thing to feature is there was a recent study from our colleagues in Latin America that looked at modifying this regimen and utilizing it in their population in Latin and Central America. So what happened was L-asparaginase was used instead of PEG-asparaginase, 6-MP instead of thioguanine, and rituximab was added if CD20 positive. And about 95 patients were treated with this AYA approach with a 2-year overall survival of 72%. So the first question I'll put out there is, can we use a pediatric regimen safely in older adults with ALL? And the short answer is at our center, we have been able to do this safely. So what we do is we take the CALGB 10403 regimen and make 2 very important modifications. We don't give peg asparaginase at more than 1,000 IUs per meter squared, and sometimes we even drop it down to 500 IUs per meter squared. And we cut the dose of steroids in half of what was used in CA-LGB 10403, the original regimen, given that most toxicity from pediatric regimens are driven by asparaginase and steroids in our older adults with ALL. So, when we're talking about toxicity, you have immunosuppression with steroids, you have bone complications, and then, of course, with asparaginase, you have hypersensitivity, thrombosis, hepatotoxicity, pancreatitis, and of course, there's the general risk of myelosuppression with these regimens. So in our cohort of 30 older adults treated with the CA-LGB 10403 dose-reduced regimen, we found a 3-year overall survival of 55%. Now, I will say there is still significant toxicity that has to be navigated. So during induction, 40% of patients had at least one grade 3 toxicity. So when you look at that, about a third of patients had hepatotoxicity, 13% of patients had thrombosis, 2 of the 30 had pancreatitis, and 1 had septic shock. And then 2 patients ultimately passed beyond induction due to complications associated with treatment, 1 due to septic shock and 1 due to hepatic failure. So relatively well-preserved survival when looking at historical older adult outcomes, 3-year overall survival, 55%, but significant toxicity even with dose reductions. So then that asks, the question that's really been in vogue in the United States is how do we still use chemotherapy, but de-escalate that chemotherapy and maybe add novel or targeted agents? So a regimen that's been studied and there's a lot of excitement around is using a regimen called mini hyper CVD. So taking the MD Anderson hyper CVAD approach and making significant dose adjustments to it and adding venetoclax to that regimen. So the table to the left details how this regimen is delivered in the context of a clinical trial. So really what's done is that venetoclax is added and you have alternating cycles. There are cycles of cyclophosphamide, and then there's methotrexate containing cycles. So you have your A cycles, which are the cyclophosphamide containing cycles, and your B cycles, which are the methotrexate containing cycles. And venetoclax is continued throughout. Up to 8 of these more intensive cycles are given before patients are moved to venetoclax plus pump maintenance, which can be continued for up to 2 years. So this was a regimen that was studied in 19 patients, of which 8 were relapse refractory and 11 were newly diagnosed. I think the major benefit of this regimen probably will come from the newly diagnosed patients. So because this was an early phase study, I think it's important to focus on the toxicity before we talk about efficacy. So when looking at toxicity, a relatively well-tolerated regimen. I will say 42% of patients did have a grade 3 or higher infection. Typically, patients can be supported through that. And then 68% of patients did have a neutropenic fever at one point or another. But other toxicity profile was fairly benign. So how do patients do from an efficacy standpoint? So when thinking about the newly diagnosed ALL patients, which are the top 11 patients on the swimmer's curve, virtually all of them achieved a complete remission with the exception of 1 patient. So 10 of 11 complete remissions, and the vast majority of those were MRD negative complete remissions. So that's marked here. So all of the remissions were MRD negative. And then when you look in the newly diagnosed cohort, excellent overall survival as well. So median overall survival, somewhere between 4 and 5 years in terms of what was seen. That being said, we probably need even longer follow-up to really define how well patients do on this long term. Most patients do not receive an allogeneic transplant either. So these patients did quite well even in the absence of transplant. The next major change in how we think about treating older adults with ALL, particularly B-cell ALL, is the use of antibody-based therapies. So we have to the left a schematic that shows the CD19 bispecific T-cell engager blinatumomab. So you have the CD19N that tags your B-cell lymphoblast, and then you have the CD3N that will activate T-cells and allow for T-cell mediated cell death. To the right, the cartoon depicts the mechanism of action of inotuzumab ozogamicin, which is a CD22 antibody drug conjugate that delivers the payload, the calicamycin, to the CD22 expressing cells and then leads to cell death. So the first regimen I'll talk about that incorporates antibodies up front is mini CVD plus inotuzumab, with or without the additional addition of blinatumomab. So this was studied and reported by the MD Anderson group, and these were patients that were newly diagnosed B-cell ALL. So the mini CVD backbone we just talked about, that was the same backbone that was used for the mini CVD plus venetoclax regimen. So this regimen uses mini CVD and adds INO as part of induction. So there were 49 patients that were treated with this induction, followed by POMP maintenance, and then 31 patients that were received mini CVD plus INO, followed by blina as part of their consolidation, and then POMP alternating with blina. So when looking at these patients, the CR rate was 89%, and of the patients that achieved a CR, the MRD negativity rate was 94%. So high rates of MRD negative CRs. When looking at the median overall survival, so with blina, the median overall survival is about 56 months. Without blina, it was 49 months. I will say this did not meet any statistical significance. So it's unclear if adding blina to this backbone of mini CVD plus inotuzumab actually improves long-term outcomes. And when you do go out to 5-year overall survival, about 41% in the blina arm, and actually the patients without blina did slightly better at 47%. So a very effective regimen. We do still see somewhat limited 5-year overall survival, less than 50%, but high rates of complete remissions and high rates of MRD negativity. So that brings us to an ongoing study that's looking to better understand how to treat older adults with ALL, and specifically B-cell ALL. So we have very little randomized data in older adults with ALL. So this is a study that was specifically designed to answer this question, with one arm being inotuzumab plus mini hyper CVD, with the option to incorporate blina. The other standard therapy is dose-adjusted hyper CVAD with the incorporation of blina. The primary endpoint is MRD negative event-free survival. So this study is actually very close to being fully enrolled. So hopefully we'll have results within the next year or so that may tell us which of these two regimens is truly a superior regimen. I also want to highlight a few other inotuzumab containing approaches in the frontline setting. So the initial one study was run out of Europe, and the schematic on the upper right shows the treatment regimen. The big takeaway is that the induction period is inotuzumab plus steroids, with additional therapy, including methotrexate, asparaginase, cytarabine incorporated in later on. And if you look at the bottom right, again, complete remission and CRI rate is quite high, about 88% after the first round of induction and 100% after the second round of induction. And of those, MRD negativity rates were about 50%. When you then further look at them beyond induction 3, the MRD negativity rate gets up to about 71%. So very promising MRD negative CR rates with an inotuzumab only based approach as induction. And if you look at survival, again, so the blue line shows the true overall survival and the dotted line show the confidence interval. So again, we're looking at a median overall survival of about 4 years. So, even with these more novel approaches, we continue to kind of fall at this 4-year number that seems to come up again and again and again. So it does seem that, even with high rates of MRD negativity, we are still seeing that long-term survival is maybe somewhat limited in older adults with ALL. And then the next study I want to highlight is a purely antibody-based approach, so chemotherapy-free. So this was in adults over 60 with CD22 expressing B-cell ALL, and the treatment regimen is 2 cycles of inotuzumab, followed by 4 cycles of blinatumomab, and that's it. That's all of your treatment. So the complete remission rate was 97% with this approach. The one major caveat is that the follow-up on this study is very short right now. So 1-year EFS was 75%, and the median EFS was not yet reached. So long-term follow-up will be needed to really understand how effective an antibody-based therapy without any chemotherapy will be for B-cell ALL, but very promising early results from this study. Other novel approaches. So this is a very nice chart that outlines the older adult kind of studies that we have, some of which we've already discussed, like the initial one or the 041703 study. But when you look at this, again, what I'll highlight is very, very high response rates. So, complete remission rates that are 90+% for the most part. And then when you think about survival, either too short to know for some of these studies, or when you look at some of the longer term follow-up, kind of a median overall survival that falls somewhere in that 4-year mark. Again, that seems to be a standard kind of thing that we are coming at. The other approach that I didn't go into too much detail about is using blinatumomab-based induction. I will say, using blina in frankly relapse disease or newly diagnosed disease can somewhat be difficult because the risk of cytokine release syndrome and neurotoxicity is significantly higher, which is why I think many of these approaches have looked at using blina later on once disease burden has been reduced. And then the one other thing I will really focus on is, should we be adding blina as consolidation as a standard across the board? So this has been a point of much conversation based on the study ECOG 1910, which was published in the New England Journal last year and led by Dr. Litzow and colleagues. So this looked at patients that were treated with a chemotherapy containing regimen. So the specific backbone was the UK ALL regimen. And what was done was, for patients who are MRD negative by flow, I will make that point again. This was by flow, not by more sensitive means of MRD testing, like NGS-based testing, which is 10 to the negative sixth instead of 10 to the negative 4. So for patients who are MRD negative by flow, they were then randomized to receive blinatumomab as part of their consolidation versus just chemotherapy. And the overall survival for those that received blinatumomab was excellent. So as you can see, approaching 80% or so. Again, these were patients that were already MRD negative. So these are patients that were likely have pretty good overall survival. But when you look at the chemotherapy only arm, the median overall survival was about 5 years. And in the blina arm, median overall survival was not reached. Now, how does this apply to older adults with ALL? Unfortunately, one of the subpopulations that did not seem to benefit from the addition of blinatumomab was those that were greater than or equal to 55 years old. So it's yet unclear whether blina should be added across the board. It does seem that for patients treated with this regimen who still are maybe MRD negative by flow, but don't have either other MRD testing done, or are still MRD positive by more sensitive tests, adding blina is a very reasonable approach. So what are some general principles to treating Ph-negative ALL in older adults? So this was a very nice review article written by Gokbigek and colleagues in Blood earlier this year. And I think it's important because it really emphasizes the patient's fitness and what therapies are available based on where you're treating the patient. So all of these things should be incorporated to then arrive at the best regimen for the patient. So if you have a very fit 55-year-old, for example, and they have T-cell ALL, you may be able to do a dose-adjusted pediatric regimen and allow them to get treated with a pediatric regimen and help navigate them through the toxicity as well. On the other hand, say you have someone who's a little more frail and you have targeted therapies, whether they're venetoclax or other kind of drugs available to you. You could think about de-escalating the chemotherapy, adding venetoclax. And then for our B-cell ALLs, the big question becomes, is there access or the ability to give inotuzumab and or blinatumomab? And when do you incorporate those? So again, if someone's frailer, if you're really worried about their ability to tolerate any chemotherapy at all, you could think about using an antibody-based approach of INO followed by blina, let's say, if that is an option or if that's available. Now let's talk about Ph-positive ALL. So as mentioned earlier in the talk, the incidence of Ph-positive ALL increases with age, and that's why I think any older adult ALL talk should have a very specific section devoted to Ph-positive ALL. So about 50% of all ALL cases are Ph-positive in adults over the age of 60. Historically, Ph-positive ALL was associated with very poor long-term outcomes, but as we've developed more and more potent TKIs, survival now has become excellent. And really, in many ways, the survival of Ph-positive ALL in older adults may be better than that of Ph-negative ALL. So why has this happened? In my mind, there's really two things. There's potency of TKI, and there's incorporation of antibody-based therapy. So the Falcon study was a randomized study that looked at ponatinib plus chemo versus imatinib plus chemo in Ph-positive ALL, and very clearly met its primary endpoint of MRD negative complete remission by the end of induction. So that was seen in about 34% of patients in the ponatinib plus chemo arm versus only 16% of patients in the imatinib plus chemo arm. So this really, I think, sets the stage and sets the mindset around more potent TKIs definitely lead to better outcomes in Ph-positive ALL in a randomized setting when compared to imatinib. Now, there is still an open question about which TKI is the best TKI to use, ponatinib, dasatinib, or others. So we'll get into the data regarding that here shortly. So another very promising approach with high rates of remission early on was the CALGB 10701 study, which looked at dasatinib plus steroids as induction. So no chemotherapy, just dasatinib plus steroids. And the complete remission rate with this approach was almost 100%, 98.5%. Later on, patients do receive chemotherapy-based treatment. So there are courses that include CNS prophylaxis with high-dose methotrexate, et cetera. So the median overall survival in this was about somewhere in the neighborhood of 3 years using this approach of dasatinib plus steroids followed by dasatinib plus additional chemotherapy. But I think this study, the really big takeaway from it is that an induction regimen to help cytoreduce or debulk a patient doesn't need chemotherapy. You can get away with a very potent TKI plus steroids or maybe some other sort of backbone. And kind of a fresh off the press study is looking at an all oral approach for treating patients with Ph-positive ALL. So this study looked at dasatinib plus the generation 4 TKI asciminib plus steroids. So the schematic is shown here. So essentially there's a prednisone phase of about 28 days, after which patients are just continued on dasatinib and asciminib. So only 24 patients treated on the study because it was an early phase study. And in terms of toxicity, if you look, so when you look at the dose level 2, which was the dose level that was arrived at, again, the most common toxicities, so hyperglycemia, we did see some musculoskeletal pain, high rates of fatigue, and some nausea, vomiting. But when thinking about more severe infections, fairly low rates of severe infections. So about 18% of patients with COVID and 12% of patients with UTIs. And the efficacy was fairly remarkable when thinking about Ph-positive ALL. So this shows the deepening of response with time. So at day 28, 19 of 20 patients achieved a complete remission, with 60% of those patients having a flow negative MRD, and only about 15% of patients had a deep molecular remission by PCR. However, when you look through time, so flow negativity improved markedly. So by day 84 of the 18 patients that had been treated for that long, 16 of 18 had achieved flow negativity. And that we were seeing some deepening of response to where 5 of 19 patients had a molecular remission 4, which is also referred to as a complete molecular remission. There is actually an amendment to this study that is selected for an oral presentation at this upcoming ASCO meeting that combines blinatumomab into this regimen of asciminib plus dasatinib. So I don't have results to report quite yet, but Dr. Luskin and colleagues will be presenting this study at ASCO in just a few short weeks. So we will get a sense of how does adding blinatumomab to this backbone of dasatinib, steroids, and asciminib potentially improve outcomes and maybe help to improve the rates of MRD negative remissions, which were not all that high with the all oral approach. On that note, let's talk about dasatinib plus blinatumomab. So we have 2 major studies that have studied this specific approach. There was the study led by Dr. Advani and colleagues that was published in Blood Advances of dasatinib plus blinatumomab that had a 3-year overall survival of 87%. And then there was the FOA et al. Study that was in the New England Journal, which really, I think, set the stage for incorporating blina into the treatment of Ph-positive ALL. It had a 98% complete remission rate and an 18-month overall survival of 95%. Now, the MD Anderson group has looked at using ponatinib plus blinatumomab So really changing from that second generation TKI of dasatinib to Blina. And again, excellent short-term survival that was seen with high rates of complete remissions. A CR rate of over 90% and a 1-year overall survival of 95% with a median overall survival not reached. We are learning more and more about what drives relapse in using this ponatinib plus Blina approach. So there is long-term data from the MD Anderson group, and it seems like the relapse-free survival is about 75% with this approach. And the major predictor of relapse is having a white blood cell count of over 70,000. So presenting with a high white count of over 70,000 is a predictor for relapse in patients treated with ponatinib plus blinatumomab. There is some discussion about whether incorporating cycles of methotrexate for patients with a high white blood cell count is needed or necessary. But I would say as of right now, we don't have any definitive evidence to say that will reduce the risk of relapse in these patients with a high white blood cell count. So given all the excitement about TKI plus immunotherapy-based approach, at the University of Chicago, myself and Dr. Stock developed a study using inotuzumab plus dasatinib. And the reason we picked INO is while Blina is a very effective drug, it can be a very cumbersome drug. So typically it's given for 4 cycles. It's a continuous IV infusion. And the way it's given is 4 weeks on, 2 weeks off. So you have patients that are requiring either a fanny pack or a pump or something that they go home with that the drug needs to be continuously delivered with. On the other hand, inotuzumab is a weekly IV infusion and can be given for 1 to 2 cycles at most. So this was a study designed by myself and Dr. Stock that looked at newly diagnosed Ph-positive ALL. And the primary endpoint was the rate of major molecular response or complete molecular response after 2 cycles of treatment. So some things to note. So we presented these data at ASH 2024, and we had 19 patients treated. So our initial treatment schema used both the dasatinib and inotuzumab in tandem. We did find that 2 of our first 7 patients developed veno-occlusive disease. So we then amended our protocol to split the dasatinib and INO. So dasatinib plus steroids was given during course 1, and INO was given as a monotherapy during course 2. So our statistical considerations are laid out here, and we were considering this to be a positive study if greater than 9% of patients, or 9 of 14 patients achieved a major molecular remission or better using our second treatment regimen. So here's schema 1, which 7 patients were treated on. So as I mentioned, initially it was dasatinib plus inotuzumab given together along with steroids. And then course 2 was also dasatinib plus INO. Schema 2, on the other hand, dasatinib alone given during course 1 and inotuzumab alone given during course 2. So of the patients that were treated, we had a fairly balanced patient representation, 53% of patients female, a median age of 60, with our oldest patient being 79. Most patients had a P190 transcript, and the IKZF1 plus signature, which has been associated with poorer outcomes in Ph-positive ALL, was seen in 16% of patients. So what was our efficacy outcome? So I'll walk you guys through this because it's set up in a somewhat confusing way to follow, but we'll start at the left and we'll work our way through. So when looking at our primary endpoint assessment, which is after 2 courses of treatment, on schema 1, the complete molecular remission rate was 71% with a major molecular remission rate of 29%. Schema 2, which is where we split the dasatinib and the INO, the CMR rate was 58%, the MMR rate was 17%, and the complete remission rate without a major molecular remission was 25%. So all patients achieved a complete remission. And when you add these 2 schemas together, 63% CMR rate, 21% major molecular remission rate, and a 16% CR without CMR MMR rate. Now, for patients who did not achieve a CMR by the end of course 2, their TKI was switched from dasatinib to ponatinib. And what we saw was significant deepening of response. So by the end of course 3 for all patients, all 19 patients, our complete molecular remission rate was then up to about 90%. Again, being able to deepen the response. And then the last thing we did was, in addition to checking for response by BCR-ABL PCR, we also used NGS-based MRD, which is at a sensitivity of 10 to the negative sixth. So by the end of course 3, 90% of patients had achieved MRD negativity using that parameter. So 17 of 19 patients achieved both CMR and MRD negativity by NGS. I will say that all patients achieved either CMR or MRD negativity by NGS. This is the toxicity profile. So about 20% of patients had COVID. We did see dyspnea in about 21% of patients. And then as mentioned earlier, veno-occlusive disease was seen in 2 of our first 7 patients. After we split the dasatinib and inotuzumab dosing, no episodes of VOD were noted. And in terms of patient disposition, so for schema 1, 4 patients completed all protocol therapy, including maintenance. 1 patient was taken off due to not achieving a complete molecular remission, and 2 patients were taken off due to adverse events. For schema number 2, which is 12 patients, we had 3 patients that completed therapy, 5 that were currently on protocol, 1 patient taken off at the end of course 3 due to detectable disease by NGS, 2 patients withdrew consent during the maintenance part, and 1 patient passed away during course 5. And then in terms of the total cohort, median overall follow-up is still short. It's only about 1 year. We have not seen any systemic relapses, and 0 patients have received a transplant, and there have been 4 deaths, 3 that happened after patients came off protocol, and 1 patient on protocol. So in summary, current pediatric approaches in older adults with ALL include using pediatric regimens and adjusting the doses or conventional chemotherapy approaches. The use of targeted therapies such as inotuzumab, blina, and venetoclax has demonstrated promising outcomes, and we do have some randomized studies that are helping us to just figure out exactly how to use these drugs. And then when it comes to Ph-positive ALL, the TKI plus antibody-based regimens have led to high rates of molecular remission. We still need longer-term follow-up to see how that translates into long-term overall survival and whether these patients may not need allogeneic stem cell transplant. So with that, thank you so much for your time and for the kind invitation today. If you do have any questions, I'm happy to take them now. Here's my email address, and here's my blue sky on social media as well. So again, thanks so much, and I will stop there.
Thank you so much. Enjoyed listening to you. Real update. We'll go to the QA session now. We have raise hand signs. So Dr. Aishwarya, go ahead.
Thank you, sir. Very wonderful talk. I just wanted to know, is your management the same for a young adult with ALL, Ph-positive ALL, and another one who's coming with CML in lymphoid blast crisis?
Good question. So for young adults with Ph-positive ALL, even in those patients, we are predominantly using TKI plus immunotherapy approach. And if they achieve a complete molecular remission, our practice is not to do a stem cell transplant. I will say that that practice varies greatly across the United States. So there's a lot of controversy for young adults with Ph-positive ALL and whether they should all be still getting a transplant or not, because we don't know what the long-term toxicity of staying on a TKI for 10, 15, 20 years is going to be. Now, for CML and lymphoid blast crisis, our approach in terms of TKI plus antibody is still the same. But for those patients who are CML and lymphoid blast crisis, those patients we do try to get to stem cell transplant as soon as they're in a remission, because we know that the rates of relapse are just essentially 100% in the absence of transplanting a patient with CML and lymphoid blast phase.
And if we don't have the option of inotuzumab, because the cost is an issue here in India.
Yeah, so I mean, there are very good data to support the hyper-CVAD plus TKI approach. So I think for young adults, using hyper-CVAD plus dasatinib or ponatinib is a very effective approach. And then, and similarly, if they have Ph-positive ALL, those patients may not need a transplant if they achieve a complete molecular remission with a chemotherapy plus TKI approach. But for the lymphoid blast phase patients, CML lymphoid blast phase patients, I would still try to give them chemo plus TKI and then get them to transplant.
Okay, so transplant is must for all. Okay.
For CML and lymphoid blast
CML,
phase,
yeah,
yeah,
CML,
absolutely.
lymphoid blast. Okay,
Yeah,
okay.
if you
Thank
can
you.
get them to transplant, I would very strongly try to get them there. Yeah.
Thank you.
Thank you, Ramesh.
So, good evening, sir. Thanks for the opportunity. So it was a very wonderful presentation with a lot of updates. So I have a couple of questions. My first question is like, understanding is like blinatumomab is a very good consolidation agent. So in patients who are not eligible for transplant, or in patients like younger patients in standard risk ALL, whom we are not attempting for transplant, and can blinatumomab be used as a like after reinduction just before starting the maintenance? Can we use it to sustain the MRD negativity in such patients?
Yeah, so the thought from the E19 study that was published in the New England Journal is that's kind of what they were looking at. The big caveat there is that blinatumomab did not replace any of the additional chemotherapy. Blinatumomab was given kind of in between consolidation and then receiving additional chemotherapy. So I don't the question is still somewhat open in that can blina replace some of the chemotherapy that we're giving for younger adults in ALL? At our center, we are not replacing any treatment with blina. We are adding blina kind of sandwich in between. The other thing I'll say is, our center at the University of Chicago, we don't use the backbone of chemotherapy that was used in the E1910 study. We use the CALGB 10403 regimen. So there are some variances there. So our approach has been we give course 1 and course 2 of CALGB 10403. If they are MRD negative by both flow and by NGS, so NGS is 10 to the negative 6th, we actually don't usually incorporate blina. If they are still MRD positive by flow or NGS, then we will incorporate blina before going back to 10403.
Is that like the reason, like with blina, the infusion, that is the problem? Because of that, you're not more willing in adding it to your patients, or like any other reason?
I mean, I think that that is part of it. I mean, it's a very difficult drug to administer in terms of the route of administration. And the other thing is, I will say, as effective as the E19 and as practice changing as the E19 study is, I think the two major criticisms are that in the United States, we have more sensitive ways of detecting MRD than flow. So we don't know if patients that are MRD negative by NGS truly need blinatumomab. And the other thing is that we, at our center, we don't use the same backbone that was used on E1910. So I think those two things make it a little harder to just widely adopt blina and give it to everyone as part of their regimen. But many centers are doing that. Many centers have said, we're going to apply the results of E1910 to whatever our backbone regimen is and just add in more blinatumomab.
Do you think there are some data on the subcutaneous blinatumomab? Like, do you think if
I
that
would
comes
love it if
into...
and when that becomes an option, because it would be a lot easier to give, because I think it's like a once
Yeah.
weekly injection. Yeah. So yeah, in AJH, I believe the MD Anderson group published on the results with subcutaneous blina, and it seems to be as effective, if not maybe more effective, as the standard formulation. The big problem is as of right now, subcutaneous blina is still not a standard drug that we can use outside of clinical trials or anything. So.
Mhm. So my next question is like, in this era of immunotherapy, like what are the clear-cut indications for transplant? Like we consider for pH positive, all pH positive ALLs, do you advocate transplant? And all KMT2A rearranged ALLs, do you advocate transplant?
Yeah, so
Like any particular mutations where you want to go for transplant, even this immunotherapy?
So I would say that the ones that still stand out to me. So I will say for pH positive ALL, we do not advocate transplanting everyone. For older adults with pH positive ALL, especially for younger adults, I think it's very controversial if you need to do transplant or not. For pH like ALL, that's a high risk molecular subset that we will strongly consider transplant. And then ETP ALL, so early T cell precursor ALL. Along with KMT2A rearranged. I'd say that those are the major subsets where even in the era of immunotherapy, even in patients that achieve MRD negativity, we really worry about the risk of relapse and try to get them to transplant if we can.
Okay. So my last question, like, what is the approach in T myeloid MPAL, mixed phenotype acute leukemia, T myeloid?
Yeah, so T myeloid, I mean, I think it depends on the age. So for older adults, I really do like the mini hyper CVD plus venetoclax approach because the venetoclax will address both the lymphoid and the myeloid components of disease. So that's really been my approach for older adults with mixed phenotype acute leukemia, particularly the T myeloid phenotype.
Okay, thank you.
Thank you, Ramesh. Take a question from the audience. Dr. Roshni wants to know what is the dose of dasatinib with chemotherapy because it is very difficult to give 140 mg of it during the maintenance phase.
So in our study, that's a great question. So in our study, we only used the 140 dose during the first 4 weeks of therapy, the induction period. After that, it's de-escalated down to the 100 dose. And that typically is much better tolerated than the 140 dose.
Thank you. Nikhil, your question.
Great presentation, Dr. Anand. Thoroughly enjoyed it and a lot of updates in it. My question is, in those regimens where inotuzumab and blinatumomab are incorporated and where the chemotherapy is cut down, what is your CNS prophylaxis strategy?
So we try to aim for at least 12 lumbar punctures with intrathecal chemotherapy. So at least 12. Some studies have even up to like 15 or 16, but it does seem like 8 is probably not enough, and at least 12 is necessary. So that's typically what we try to do is over the course of therapy, administer 12 lumbar punctures with IT chemo, and that is assuming they were CNS negative at diagnosis.
And were CNS positive patients included in those trials, especially the chemo-free regimens, or was it an exclusion criteria?
It's so most of those excluded CNS positive. Now you could be CNS positive, clear your CNS, so get frequent lumbar punctures and then enroll on study. But in general, you had to be CNS negative by the time you enrolled on study.
And just one more question. What is your induction strategy for older patients who have ETP ALL?
So we have participated and gotten very comfortable with the mini CVD, mini hyper CVD plus venetoclax approach. So if we are able to get venetoclax approved for those patients, that's what we've tended to go towards. I know that the MD Anderson group has published on hyper CVAD plus asparaginase for older patients, and it does seem like ETP ALL benefits from the addition of asparaginase. But you're trading efficacy for toxicity. You have to be very,
Yes.
very, very convinced that your patient will be able to make it through receiving something like hyper CVAD plus asparaginase.
And in these patients, we have had quite a few patients who are primary refractory to mini hyper CVD with venetoclax, even older and slightly younger patients also. So in the context of ETP ALL, do medications like bortezomib, daratumumab help in these patients? Or would
Yeah,
you
I mean
prefer giving something like a flag if the patient is young and fit?
so in the we tend to use a nelarabine based approach for relapse refractory T cell ALL, so like the Nectar regimen or something like
Yes.
that for the relapse patients or the refractory patients. I'd say the data for bortezomib are very, very scant in terms of its activity. I know that there have been children's group studies that have incorporated into, for example, TLBL. In daratumumab, the main role there, I think, is whether it's a good MRD eraser for T cell ALL. But again, in bulk relapse disease, daratumumab tends to have very limited activity. We do use it if we don't have anything else left to add. The other thing that's shown some promise for patients who are venetoclax naive is there are now some experiences of azacitidine venetoclax in T cell ALL. And then the last thing I'll add is many patients with T cell ALL will have mutations in what we think of as typical myeloid genes. So our
Yes.
group has published on using IDH inhibitors and FLT3 inhibitors in these patients if they were to have a IDH or FLT3 mutation, and we've seen fairly good efficacy with that approach.
Great, fantastic. One last question. What is your strategy for a patient with isolated CNS relapse? Older patient versus a young patient?
So for young patients, obviously reassess the marrow and ensure that they don't have a systemic relapse along with CNS. But assuming it's a pure CNS relapse, typically our goal is to clear the CNS and then offer craniospinal irradiation. We do typically then try to take those patients to allotransplant if they have not been transplanted. For older patients, if they're not transplant eligible, again, yeah, clear their disease with intrathecal therapy, offer craniospinal irradiation, and then see where, I think ultimately the big question becomes is, are they fit enough or well enough to then receive transplant or not? One thing that's becoming kind of an open question for the B-cell ALLs is CAR T-cell an effective consolidation for isolated CNS relapse? So in Blood Advances, there was just a real-world analysis of patients treated with Brexucel or Tecartus, and that does seem to show that Tecartus does do a good job of controlling CNS disease in those that had a CNS relapse. The other FDA-approved therapy for older adults with ALL in the United States is obe-cel, but we don't have any data yet about CNS because those patients were not enrolled on study, and the drug has only been approved for a few months, so we don't yet have any real-world data.
Once again, wonderful lecture. Thank you.
Thank you.
Thank you, Nikhil. We'll take a question from the audience. There's a question from Myanmar about your experience with Nelarabine.
Yeah, so I mean, I think with regards to Nelarabine, it is an approved therapy for relapsed refractory T-cell ALL. CR rates are limited, 15 to 20%. And in general, on retrospective studies at least, it seems that chemo plus Nelarabine has better outcomes than using Nelarabine as a single agent. So we have not incorporated Nelarabine into the frontline treatment of T-cell ALL, with the main reason being is that the children's group studies that enrolled up to the age of 30, when you specifically look at the 18 to 30-year-olds, they did not seem to benefit from Nelarabine in terms of disease-free survival the same way that the younger patients do. And I'm an adult hematologist. I don't treat anyone under the age of 18. So I know that our pediatric colleagues regularly incorporate Nelarabine into the frontline treatment. In general, our approach has been to use Nelarabine at relapse or with refractory disease, or if someone's MRD positive and we say need to try and deepen their response.
Thank you. Bharat, your question.
Thank you, sir. Very wonderful presentation with very useful updates and useful information. Already my question is partly answered that during maintenance, dasatinib is de-escalated to 100 milligram. I would like to know what should be the frequency or maintenance duration with dasatinib, utilizing at what frequency we perform MRD, either by flow or NGS, and how long?
So so in general, we will check MRD every 3 months by the peripheral blood. So once someone has achieved MRD negativity in the bone marrow, we typically will monitor the blood moving forward. Dasatinib, so we try to keep them at the 100 dose for pH-positive ALL as maintenance. Occasionally, we've de-escalated patients to 70 milligrams if they've had significant toxicity, and it does seem like those patients have maintained their MRD negativity. The other thing we've done on occasion is if someone is having significant toxicity, we'll switch them from dasatinib to ponatinib at the 15 milligram dose. Once patients are kind of in the maintenance phase, we will try to check MRD every 3 months or so from the peripheral blood.
Thank you.
Thank you, Bharat. Another question from audience. Dr. Roshni wants to know, if you get seizures with blinatumomab, can you give it further or it's further contraindicated to continue?
Yeah, I mean, I think it depends on whether what was kind of the context of the seizure or whether there were other things contributing. But in general, if they were controlled seizures and the patient is now on an anti-epileptic and a stable regimen, I would say you could probably re-challenge with Blina, but what I would do is you probably need to have them on that 9 microgram dose for at least a week before you step them up, and then watch them on the 28 microgram dose at least for 2 to 3 days before they were to leave the hospital or otherwise on it. But, seizures are very worrisome. And particularly if it was to say like status epilepticus or something like that, I would be very hesitant to give Blina again.
Thank you. Dr. Dev Ranjani, your question.
Thank you, sir. That was a brilliant presentation, sir. So my question is, in younger adults like 39, 40 years of age, when we use pediatric-inspired protocols using Pegis-Pagenis, we classically use an icicle protocol, which we use. So do you reuse or re-challenge pegaspargines after you have had, say, grade 3 or grade 4 hepatotoxicity? Or do you eliminate the pegaspargines completely? And if you do eliminate completely, do you stick to icicle protocol or pediatric-based regimens any further, or do you switch over protocols in younger adults?
Yeah, great question. So, I'd say for patients who have grade 3 hepatotoxicity related to pegasparaginase, if there is complete resolution of the liver enzyme abnormalities in the bilirubin, we will re-challenge and often at a lower dose. So I will say, and we're working on putting this data together now. It's not yet published, but we presented it at ASCO as an abstract last year. We've actually, at this point, outside of clinical trials, we cap our pegasparaginase dose at 1,000 IUs per meter squared for all patients, young adults or older adults. And then the total dose is capped at 3,750 IUs. So that has helped quite a bit with the toxicity profile. And then for patients who still have hepatotoxicity, we will usually bump down from the 1,000 IUs to 500 IUs per meter squared if they have complete resolution of the hepatotoxicity. Now if you re-challenge, and again, they have a very significant LFT abnormality, at that point, we will omit the pegasparaginase. And then I think it depends on whether someone has achieved MRD negativity or not. Like if they're MRD positive and say they have B-cell ALL, we would likely incorporate blinatumomab to try and offer some deepening of response. On the other hand, if they've already finished, say they've already gotten through induction consolidation and we're at delayed intensification or something like that, we will probably drop the pegasparaginase moving forward from there and just continue with the pediatric inspired protocol.
Thank you.
Thank you. Question from audience. Dr. Hitha wants to know, how do you select your patients for venetoclax?
Yeah, so in general, I would say we tend to, for patients under the age of 50, we will try to use a pediatric inspired regimen and then adjust the dosing of that regimen if needed, like we were talking about with the pegasparaginase and steroids. For patients over the age of 50, if they are T-cell ALL, we'll use a venetoclax-based regimen. If they are B-cell ALL, it really comes down to, I'd say, the patient's other comorbidities. So for our very frail patients, we will typically use inotuzumab followed by blinatumomab and not use a venetoclax-based approach. For our more fit patients that are kind of in that 50 to 60 range, we will use the mini CVD plus venetoclax approach. For over 60, I'd say for the most part, for B-cell ALLs, we're using purely antibody-based approach. For the T cells, we still will use mini CVD plus venetoclax because we don't have any antibody-based therapies for them.
Thank you. She has another question. Your experience with FLT3 positive ALL.
Yeah, so again, we've published on this in BJH, and I can try to put the study in the chat. It's limited experience, but we have had a patient that was FLT3 mutated that we treated with gilteritinib plus venetoclax, who achieved a complete molecular response with T-cell ALL. Now that response was quite short. It was only a couple of months. We were trying to get him to another transplant and unfortunately did not get to another transplant. But for FLT3 mutated ALL, if you have run through other standard options and you are able to access a FLT3 inhibitor, I think it's well worth trying. And you could potentially do a FLT3 inhibitor plus venetoclax if they have not seen venetoclax yet.
Thank you. Shilpi, your question.
Thank you, sir. I am a hematopathologist. Thank you for the excellent and insightful presentation. So I have a question regarding CD22 targeted therapy. In past flow cytometric studies have shown downregulation and even loss of CD22 expression in the residual blast in approximately 10% of relapsed refractory BLL. So, do you recommend routine assessment of CD22 expression levels before initiating inotuzumab?
I would. So all of the studies that have specifically utilized inotuzumab have required expression on 20% or more of the lymphoblasts. So I think we have very sparse data to support utilization of inotuzumab if there's not CD22 expression. The other thing I'll add is we've actually been able to retreat patients with inotuzumab if they have a subsequent relapse that's still CD22 negative. So many of these patients will actually retain their CD22 even at relapse if they've been inotuzumab exposed. And for those patients, we've actually been able to successfully retreat with inotuzumab. And I've shared that reference in the chat as well. But yes, I would encourage for any B-cell ALL to routinely incorporate CD22 expression into the flow studies that are being done.
Thank you. A question from the audience. This is regarding duration of TKI maintenance. How do you decide?
So right now, I will say our data for stopping TKIs in Ph-positive ALL is very limited. So we have a couple real-world studies, one that was published in Hematologica and one that was published by the MD Anderson group by Nitin Jain and colleagues. And all of those, the reason for stopping TKI was patient preference. So our standard right now is to still give a TKI indefinitely for Ph-positive ALL if someone does not go on to allo transplant. Now, for patients that receive an allo transplant, the post-transplant maintenance is usually about 1 year to 2 years, depending on the center with the TKI.
Okay, and the last question is, will you always prefer ponatinib for all patients of Ph-positive ALL?
I don't. So our study uses dasatinib in the frontline setting. So for patients who achieve a complete molecular response with dasatinib, they stay on dasatinib. Now, I think where I like ponatinib is if someone has not achieved a complete molecular response after 2 cycles of therapy, switching them to ponatinib to deepen that response seems to be a very effective approach. The other thing is it does seem that dasatinib penetrates the CNS better than ponatinib. So perhaps we get some extra CNS protection with dasatinib. Now, we don't know that definitively, but there's at least the potential for that.
Thank you. Dr. Nidhi? Are you there, Dr. Nidhi, and you have a question?
Sorry. Yeah. Sorry, can you hear me, sir, now? Yeah.
Yes.
So
yeah.
I have a question regarding CML with lymphoid blast crisis. If you can, most of the time we consider these patients for transplant. A young patient with CML lymphoid blast crisis, you will try to get the patient in remission with either a pediatric inspired protocol or a hyper-CVAD based therapy with a TKI. So I want to ask you, when do you exactly consider these patients for transplant? Like, what is the timeline? If I'm using a pediatric inspired protocol, do I do a month of like induction and check the MRD status? If the patient is already MRD negative after the induction, should we that time consider the patient for transplant, or should we consolidate and then consider them for a transplant? So the timeline from what you practice. Yeah.
I would try to take them as quickly to transplant as you can after they achieve MRD negativity. So if you can take them after induction, that's fine. The big issue with lymphoid blast phase, though, is unfortunately, it's very difficult to get them MRD positive or MRD negative. So, for many patients, if they are in a hematologic remission after 2 cycles of therapy, but still have MRD positivity, we still will try to move forward with transplant, because I don't think giving a 3rd cycle of therapy is going to deepen the remission. If anything, I think it just will allow them more time to potentially have a relapse of disease before we get to transplant.
Okay. Thank you.
Thank you, Nidhi. One more question has come up is, for Ph negative ALL, post-transplant, any maintenance therapy is required?
We typically are not giving maintenance therapy post-transplant for Ph negative ALL. And I'm not aware of any data to support like post-transplant Blina or anything like that as far as I'm aware either.
Okay. Yeah, I think that's it. Rest of the questions are all repeat questions. So anybody from here, any question? No, in that case, Dr. Anand Patel, thank you very much. You spared your
Thank you so much for having me. I really enjoyed it. Such wonderful questions, and thanks so much for taking the time.
Thank you. And have a wonderful day ahead. And good night to everybody from India. We'll meet tomorrow morning, 11:30.